Good morning, everyone. My name is Jody, and I'm moderating this session, and I'm very pleased. This is session 221. Did I say that right? Sorry,
Yes,
let me just,
number.
yes, 231, my apologies. And the title of the session is Biomarker Testing, Advanced Cancer that Needs Testing to Look for the NTRK, Ret, and Other Therapeutic Targets. And I'm very pleased to introduce Dr. Naifa L. Busaidy. She's an endocrinologist, and she's also an associate professor in the Department of Endocrine, Neoplasia, and Hormonal Disorders at the University of Texas MD Anderson Cancer Center in Houston, Texas. Dr. Busaidy is the director of the Thyroid Nodule Clinic and specializes in thyroid cancer. She has authored numerous peer-reviewed research articles and book chapters. Dr. Busaidy is a recipient of the ThyCa Thyroid Cancer Research Grant and has spoken at many ThyCa conferences and serves as a ThyCa medical advisor. So we really appreciate that very much. We have a large group here, and I'm going to turn it over to Dr. Busaidy. She'll let you know, but I think at this point we have a really large group. So we're going to hold questions until the end. So with that, I'll turn it over to Dr. Busaidy.
Okay, good morning, all. It's nice to virtually meet all of you. I love ThyCa, and what we're really missing this year is the personal interaction. But lots of blessings have come out of this, right? The number of attendees at this conference is fantastic, and we all now have the ability to be able to listen in and learn. So normally I make my talks interactive for those of you who I haven't met before, and I, love you asking questions as you think of them. But unfortunately, it's not going to work when we do it virtually. So what I'm going to ask is what, was mentioned, is that just write your questions as you think of them, so you don't wait till the very end and then you forget them. And then what we'll do at the end is I'll try and address them and go through them. And if the session has to end, I will stay on to just answer those questions in the chat box, not in the room. Okay. All right. So I'm going to share my screen. So this, and I love ThyCa, and thank you all for all your support and help, and know that without all of you patients, none of this would be possible. So this session is called Biomarker Testing and when and how we order it. And so I'm going to talk a little bit about the definitions of some of these things and go from there. So I want everybody to remember, right, that thyroid cancer, there's 4 major types: papillary, follicular, medullary, and anaplastic, and their incidences are on the right. So the most common is the papillary thyroid cancer, but there may be some in the room that have follicular thyroid cancer. Medullary thyroid cancer only makes up about 45% and anaplastic 1%. But I'm going to try to talk a little bit about biomarker testing in all of them and what its role is. But because the vast majority of thyroid cancers are differentiated thyroid cancer, which is papillary and follicular combined, I'm going to spend a little more time on the differentiated thyroid cancers. Okay. So keep in mind, before we even talk about biomarker testing, that the standard therapies for differentiated thyroid cancer is surgery, radioactive iodine, and then sometimes further surgery and further radioactive iodine, and and thyroid TSH suppression, or giving you a little more thyroid hormone than your body needs to keep the cancer from coming back. And for the vast majority of patients with differentiated thyroid cancer, that's papillary follicular, these 3 treatments work great. And even if you have some disease left over, for the vast majority of those patients who have metastatic disease or have a little bit of disease, that the extra thyroid hormone or the TSH suppression still works. So these are not the patients that we're going to be referring about today, but we'll talk about why that is. And then for medullary thyroid cancer, the standard is surgery, and then if it comes back, typically more surgery, right? Those are the only chances of becoming cancer-free. So when we talk about all those other systemic therapies for advanced disease, that's a minority of patients. Okay. And then for anaplastic thyroid cancer, it's systemic therapy or traditional treatment that goes throughout the body, and then potential surgery, and then back on systemic therapy. Okay, so all three of those categories of thyroid cancer have different approaches, but for at least for medullary and differentiated thyroid cancer, for the vast majority of those patients, one does not need systemic therapy. And then we'll talk in general, therefore, probably not biomarker testing, but we'll talk about some of the controversies. So for differentiated thyroid cancer, which makes up the vast majority of thyroid cancers, just to keep in mind, the total differentiated thyroid cancer cases, if you took them all those patients as a whole, and that about a third of them will recur, but only 10% of them are metastatic, and 5% of those will be what's called refractory to radioactive iodine. And I know you have lots of sessions on systemic therapy and cancers that are refractory to radioactive iodine. I'm just going to go over a couple of things before moving forward with biomarker testing, because I think it's important to have all of this in context. So the many treatment options for metastatic disease: if you have DTC, then it's TSH suppression. If your tumors take up iodine, it's radioactive iodine. But then there's all these localized therapies, right? So sometimes it's some radiation to different body parts. Sometimes it's a little bit of surgery. There's all sorts of what's called ablation, embolization, freezing, and there are other sessions that you've probably heard about these. But we have options for patients with metastatic disease. And then if somebody's disease is growing in multiple places, we talk about systemic therapy, where there's traditional chemotherapy or cytotoxic chemotherapy, which we don't often use in most of these cancers. And then there's targeted therapies. We do have to remember that most differentiated thyroid cancer patients with metastases still take up radioactive iodine, and that is the original targeted therapy. And that patients whose tumors do take up radioactive iodine, that radioactive iodine plays a big role. It does improve survival. So this talk is, when we talk about biomarker testing and systemic therapy, we're not poo-pooing all the other treatments that are out there. They're still good. There's a role for each one of these. And then for differentiated thyroid cancer, there's thyroid hormone suppression therapy, of course, and that works in the setting of metastatic disease. And we just have different goals of where that TSH should be. And that giving you a little more thyroid hormone than your body needs, or TSH suppression, it does improve survival in patients with advanced disease. So when we talk about all these other treatments, we don't want to forget doing these basics and maintaining these, right? Maintaining the TSH suppression, even if you're on systemic therapy and chemotherapy. And then, of course, we have site-specific treatment of metastases, meaning if I have a metastasis or a thyroid cancer spread to the brain or to the bone, I can do surgeries or radiation or use bone-modifying agents. So there are these other treatments that you've heard about in other sessions. So when we see a patient with cancer that's distant metastases, or when we refer to advanced cancer, we're talking about patients who it's spread outside of the neck, or it's in the neck and it cannot easily be removed. Okay, so evaluation of those patients is, there are 5 key questions we look at. One, where is this metastatic disease? Where is this tumor that's spread outside of the neck, if it is outside of the neck? Or where in the neck is it? Is it near blood vessels or voice box or food pipe? Is the disease, does it take up radioactive iodine? And if it doesn't, we call that radioactive iodine refractory. Does the patient have symptoms? And are those symptoms from their cancer? What's the size of the tumor? And is it going to interfere with other organs? And then has this disease, that spot been like that for a long time? Or is it progressing or growing? So these are very important questions that your health team and yourself are asking, right, when you're assessing the patient in order to determine what's the best next treatment. And then, of course, we have to keep the definition of radioactive iodine refractory differentiated thyroid cancer in mind. You know, they're either patients who we know have tumor somewhere from some other scan, but it's not taking up any iodine, or they had iodine within 6 to 12 months, and yet it still grew in that area, or they've had a total of 600 millicuries of radioactive iodine in their life. And oftentimes, if the tumor takes up FDG, the radioactive sugar, then those tend to be more resistant to radioactive iodine. So the American Thyroid Association has put out guidelines. If patients have metastatic disease, metastatic thyroid cancer that is refractory to radioactive iodine, or in the case of medullary, they have medullary thyroid cancer that cannot be surgically removed, but then those are patients you can watch. because we don't have a cure for differentiated thyroid cancer but beyond radioactive iodine, and for medullary thyroid cancer beyond surgery. So we have to take each patient as an individual and know what our limits of our treatments are and what are the potential issues with the disease. So for differentiated thyroid cancer, if it's metastatic disease, asymptomatic, not growing, we just keep them on a little more thyroid hormone than their body needs, because that is anti-cancer therapy. For the patient with medullary thyroid cancer, if it's not surgically resectable, or it's can't be taken care of with local treatment, then you often just watch it. Extra thyroid hormone doesn't help in that case. What about patients who have progressive disease? So when patients have thyroid cancer that's growing, then we have systemic therapy or clinical trials, okay? And that systemic therapy is often called targeted therapy, or you hear the words kinase inhibitor therapies. And we're going to talk about why they use those words. So there are targeted therapies that are FDA approved for thyroid cancer. For differentiated thyroid cancer that is progressive, that's growing, and refractory to radioactive iodine, there's sorafenib and lenvatinib. And we're going to talk about some of the newer agents in a second. And then for medullary thyroid cancer, that's progressive, there's vandetanib and cabozantinib, okay? And for anaplastic thyroid cancer, if it has a BRAF mutation, there's dabrafenib and trametinib. Now, any thyroid cancer that has an abnormality on one of its genes called NTRK, there are two drugs that are FDA approved for any cancer, doesn't have to be thyroid, that has that NTRK or NTRK on it. So thyroid would be included in that FDA indication, and we're going to show you some data why. And then patients whose tumors, when you test the tumor, have something called MSI or microsatellite instability that's high, then it's pembrolizumab or one of the immunotherapies is FDA approved. So what we're seeing here, why we're getting into the biomarker portion of this talk, is that drugs in all cancers, but even in thyroid cancer, which is more exciting than in any other cancer, right? Because that's what we're all here for, is that these drugs are getting approved based on personalized what that patient's tumor has on it. What are the genes, what are called oncogenes? What are the proteins that are making that cancer grow? And can I use a drug to stop it? Okay, so that's what we're talking about in general when we use the word targeted therapy, but more importantly, genomic driven medicine, right? They're trying to do this in all aspects of medicine, but thankfully thyroid cancer got on board and we are now part of that. So targeted therapies are more specific to cancer cells, not just simply like traditional chemotherapy where they break down rapidly dividing cells. And the goals of using targeted therapy instead of just traditional chemotherapy is that it's less harm to normal cells and it's more effective against cancer cells. But still, it does have side effects because it does hit normal cells. But the goal is to have less effect on the normal cells. So what I tell my patients is that when we talk about systemic therapies, they're all forms of chemotherapy, because the word chemotherapy means drugs that go against the cancer, okay? But these targeted therapies don't just go breaking down fast-growing cells, they're trying to attack the cancer cell. Radioactive iodine is a form of targeted therapy because it's targeting cells that make iodine, okay? Now, when we look at targeted therapies, we have to understand the individual cancer and what drives the cancer. So it's like an alphabet soup, right? You look, and in a cell, in a cancer cell, or in any cell, there are multiple pathways that make a cell go, okay, that make them drive, they're like signals. It's a big communication in a cell saying, hey, okay, grow more of these cells, grow less of these cells, kill off these cells because they're dead or they're old in my body. And those signals are constantly working. Some of those signals go by what's called kinases, okay? So you'll see these Y-looking things on the end of a cell. Those are all tyrosine kinase receptors, the vast majority. There are obviously other types of signals. But when we have those, they are signals saying, hey, give me a protein and tell me go. Okay, and then you have all these pathways down here in the cell that once they go forward, they tell the cell grow, grow, grow. So what can happen is if you have a mutation or an abnormality on one of these signal accepting receptors, or in one of these pathways, any of these letters, if there is a change, a mutation, anything can go wrong, then it can switch the switch on to on, and it says grow cell, grow cell, grow cell. So it's like a growth factor, or like a change in the signal to communicate to the cell, keep growing. Okay. And so when we talk about biomarkers, what we're talking about is, are there ways that I can look into the cancer cell and try to measure what's driving it and making it grow? Okay. And so to understand that, we have to look at a large series of thyroid cancers and say, hey, what are the general drivers of thyroid cancer? And those are the words you hear people throwing around: oncogenes or oncogenic drivers. So in thyroid cancer, we have some common pathways, okay? So for differentiated thyroid cancer, see here in the center, the blue BRAF or BRAF, that is the most common mutation in differentiated thyroid cancers and in anaplastic thyroid cancers. Because remember, differentiated and anaplastic thyroid cancers come from the general cell called the follicular cell that makes thyroid hormone. So you can see why their mutations or their abnormal genes would be more common. So 40 to 70% of papillary thyroid cancers have a BRAF mutation. 50% of anaplastic thyroid cancers have a BRAF mutation. So that's actually the most common mutation seen in the follicular cell-driven cancers, the differentiated and the anaplastic, okay? But now in those same cancers, you can have RAS mutations shown here. You can have these what's called gene fusions, Ret PTC, and we're going to talk about Ret in a little more detail. There's another fusion that's not shown here called NTRK or NTRK, which we're going to talk about. And then in the more advanced cancers that are follicular cell driven, like the differentiated and papillary, you can have a PI3 kinase, AKT, and mTOR, the green shown here on the left. Now, all these letters fall in certain pathways and help drive the cancer. And so you can see why people work quickly, scientists, industry, all together, to try to develop drugs that inhibit any one of these pathways. And these pathways can be very common to many cancers. And so trying to figure out which pathways are common, which can we target in any individual's cancer. Now, in medullary thyroid cancer, we often have this RET, but they're Ret mutations, and we'll go over that. And so those can be targeted, and we have RAS mutations shown here. So the biomarkers common to thyroid cancer, there's lots of biomarkers, and I'm only showing you here the ones that are most common, right? So in differentiated thyroid cancer, which throughout the talk I'm going to call DTC, and anaplastic thyroid cancer, which throughout the talk I'm going to call ATC, you have most commonly BRAF, you have RAS, you can have Ret fusions, you can have NTRK or NTRK fusions. And in medullary thyroid cancer, about half of them have Ret mutations, and a little under 40% can have RAS mutation. So there's a small percentage of patients that don't have either, okay? So these are the biomarkers that when people are looking at drugs, either your healthcare team or, as an individual, when we're thinking about targeted therapies, these are the mutations we're sort of looking for when we test for them. And then when you look at a tumor cell, and then you look at endothelial or the blood vessel cells around it, you can look at what are these receptors, kinase inhibitors, what goes down in a cell, what's driven by this tumor, and then an individual drug, what does it inhibit or what does it stop? So this is just an example here I pulled to show sorafenib. The green X's are what it inhibits. So it inhibits BRAF weakly, Ret PTC weakly, and vascular endothelial growth factor is the blood vessel. And now I'm not showing you this to teach you about sorafenib. My point was, you have these cell pathways normally working in a cell all the time. And then in a cancer cell, one of those normal pathways that normally have an on and an off switch, the on switch is turned on, flipped on, and stays on the whole time, so it keeps growing. And those drugs, the targeted therapies, are going in there to turn that switch back to off, if that makes sense. Okay, so how do we test for biomarkers, right? Are there markers that can help us predict who's going to respond or that work in these cancers? And so there's different ways to measure biomarkers. The most common and the one that's mostly approved and is proven in thyroid cancer is tissue, and in most cancers is tissue biopsies for what's called somatic mutations, okay? So it's putting a needle in your thyroid cancer, wherever it may be, when it's in when the thyroid is intact, or when it's in the lungs or in the bone. You can biopsy where the cancer is and ask, the question in the lab, which of these genes or proteins are abnormal, okay? This can be done on tissue that's already removed. It doesn't have to be freshly done, but there are certain testing ways that have to be on fresh tissue. There's plenty of companies that do it, and many of the institutions that all of you are seen at actually have a way to do this. It's not necessarily that one is better than the other or that people have compared them head to head. Each one of those, once they are clinically available, have been validated and tested. The liquid biopsy or blood biopsy is when you take the patient's blood who has thyroid cancer and you're looking if you can measure that gene in their blood. Most commonly, that's called circulating tumor DNA. But this is where it gets confusing, because when we talk about genetic testing, we have to be very careful, right? The vast majority of people think genetic testing is looking for a hereditary tumor or hereditary a test that will tell me, am I at risk for a certain cancer? And you're absolutely right. That is called genetic testing, and that's the most common type of genetic testing. So 5 people in my family have breast cancer. One of them had this blood test that told them they had the familial kind of breast cancer. And so I want to have that testing. It's called BRCA as an example, BRCA. Okay, that when you have genetic testing that shows those mutations or abnormalities, that is in every cell of your body. Okay, so that is hereditary genetic testing, what's called germline. Okay, when we talk about somatic mutations, there's a way in your blood, if your tumor is shedding cells, then in your blood, sometimes you can measure that BRAF, okay, from the cancerous cell. A certain percent will show up, but that does not mean it's hereditary. Okay, so there's 2 different ways of measuring it that can use the blood. The liquid biopsy is not very common in thyroid cancer because it tends to thyroid cancers tend to only shed in the liquid in very advanced disease. So typically anaplastics and sometimes in advanced medullaries. It's not so good for differentiated thyroid cancers. Okay, so circulating tumor DNA is that blood test. And this was just a picture to show if somebody has a cancer, then the cells are dying. That's called apoptosis or necrosis. They can get secreted and they can throw some DNA, some tissue into your blood, which we can measure. So it's not in every cell of your body. It's only if the cancer is shedding it. Okay. So this was just a slide to show you that in anaplastic thyroid cancer, 84 to 95% of the time, if a patient has a BRAF mutated anaplastic, we can pick it up in the blood. But see here, for the papillary thyroid cancers, we only pick it up about 1/3 of the time. And for medullary thyroid cancers, if they had a Ret, we picked it up about half the time. Okay, so the blood test to see if your tumor is shedding may only be good in the more advanced disease, and we have data mainly on BRAF and Ret. So I want to give a case example before we go into some of these drugs, okay? 55-year-old gentleman who had his thyroid removed, radioactive iodine, thyroid hormone. Oh, I'm sorry, he had papillary thyroid cancer. He had his thyroid removed, radioactive iodine, thyroid hormone, and over time, he was noticed to have lung metastases, or the thyroid cancer had, spread to his lung. So he was treated with sorafenib, but he had a lot of side effects, unfortunately, so that had to be stopped. And then he was treated with lenvatinib. For about a year, his tumor shrunk. He did very well. But then after a year, unfortunately, his cancer progressed. He developed some shortness of breath. He had fluid in the lining of his lungs called pleural effusions, okay, that then can potentially squish your lungs and you can become short of breath. And he was placed on oxygen. They put in what's called Denver catheters, which are basically catheters on the side of the lungs to help drain that fluid and then expand the lung. And the question is, what should we do next in this patient? He's gotten, and at this time, this was many years ago, only sorafenib and lenvatinib were FDA approved. So this is the white dots within his lungs, or what his thyroid cancer had looked like. This is a CT scan slices take slices of the body while you're lying down. And this is just one slice. And then before we start anybody on any sort of targeted therapy or chemotherapy, and anytime we're changing drugs, we always do an MRI of the brain to make sure they didn't get any evidence of thyroid cancer in their brain. Why? Because if they do have any thyroid cancer in their brain, we treat that first before the rest of the body, because there isn't much there isn't much space in the skull to have things expand in there. So, and they can bleed. So those become more of the emergency. So he had a couple of small spots. See here, this white where the arrow is 2 millimeters. So the thickness of 2 dimes, and then another spot here where he had some thyroid cancer. And so the question is, what would we do? So we had tested his tumor, and he was found to have a BRAF mutation. And so we wrote to his insurance, because BRAF inhibitors, which are drugs that stop that BRAF, are not FDA approved for thyroid cancer, except for anaplastic nowadays, not then, and they're not approved for papillary thyroid cancer. So we talked to his insurance and said he's progressed, or his cancer has grown on the lenvatinib and sorafenib, and we need this, and his cancer has this BRAF. In his biomarker testing showed that he had this BRAF mutation, and dabrafenib is a drug that inhibits or stops that BRAF. So we managed to get a drug that stops the BRAF. And we know from these BRAF inhibitors were approved in melanoma first, and they've done trials in patients who have the thyroid cancer in the brain, I'm sorry, not the thyroid cancer, the melanoma, BRAF mutated melanoma in their brain, that these drugs can shrink that. So we said, hey, these are small brain tumors. We worked with our neurosurgeons, and we started him on a BRAF inhibitor against what his tumor tested for, right? The BRAF mutation was present. So in a few months, he did well. He's off his oxygen. He had the catheters out. His MRI of the brain no longer showed brain metastases. His PET scan showed that everything had improved in his bones and his lungs. So this drug is not a cure, and that's not the purpose of me telling you this. My point is, we need to be thinking about biomarker testing, especially in advanced disease. So when we think about, well, now there's so many drugs out, how do we choose them? We have sort of an algorithm. This is not in the guidelines. This is how we do it at MD Anderson for patients with radioactive iodine refractory differentiated thyroid cancer. And my purpose of showing you this is not to dictate how care should be, to tell you why biomarker testing can be helpful, right? So if we have patients, we have their tumor, whether it's the older tissue that's already been removed or we have to get a fresh biopsy, we then will order tissue testing or mutation testing for thyroid cancer. And if you see you have a BRAF mutation, okay, and if their tumor is like grabbing or surrounding blood vessels, that maybe one of these other FDA approved drugs may be harmful, or starving the tumor of its blood supply may cause a problem. Or sometimes if the tumor is invading the food pipe or the voice box, that may be a reason you want to be careful with sorafenib or lenvatinib. Then we would go and talk to the insurance about getting a BRAF inhibitor, okay? But if there's no reason not to go for sorafenib or lenvatinib, then you could do either, right? You could do the BRAF because they have the BRAF mutation, or you could do the lenvatinib or sorafenib. If they have one of those rarer mutations that I'm going to show you some data for, NTRK or Ret, well, at the time, we were always putting them on a clinical trial. Now these drugs are FDA approved. So we'll consider putting them either on the sorafenib, lenvatinib, or the NTRK Ret. But now that they're approved, we would probably go straight for the selective drug. And then if they don't have a BRAF mutation or one of these rarer mutations, then we would go for lenvatinib or sorafenib, because we do know that those drugs work, again, even if a patient has a BRAF or an NTRK or a RAS or anything else, because they're more generalized drugs. Okay, so what about these others, the Ret and the NTRK? So NTRK stands for neurotrophic receptor tyrosine kinase inhibitor. So that's just a fancy long word, but it's talking about, remember on the cell, I showed you those Y-looking things where they receive the signal to grow or not to grow. So this is a kinase, a tyrosine kinase, right? Called NTRK. And so sometimes rarely in differentiated thyroid cancer, which is the papillary and follicular, and an anaplastic thyroid cancer, you can have an abnormality or an alteration on the cell called NTRK gene fusion, right? How do we know this even works? Well, there are 2 drugs now that are FDA approved for people who have NTRK genes, no matter what cancer you have, right? And how did that come about? So this is just an example of one of them, larotrectinib. They looked at these drugs and said, hey, this TRK has an ABC and different types of TRKs. And they said, this is an oncogenic driver, or this is a gene that gets changed in many cancers. And this is just a picture. I don't expect anybody to be able to read this or memorize it, but to show you that there are many different types of cancers that have this NTRK. And thyroid was one of these that they found. And it's this little green thing shown here right now, right? It's a small percentage of all cancers, as you know, but a very important one. It's the most important one to all of us in this room, right? Or in this virtual meeting. So in a rare, in thyroid cancers, this can be found. And this is something called the Waterfall Plan. I don't know if in the other sessions they taught everybody, but each bar represents a patient. And if the bar is going up, the patient's tumors grew. If the bar is coming down, then the patient's tumors shrunk. And this line here, typically you'll see this on all the trials, is when it shrunk enough to call it true shrinkage or partial response, okay? So again, they were showing that no matter what the patient's cancer type is, if they have this NTRK gene alteration, that these drugs, these NTRK inhibitors, can shrink the tumor. Now, they're not cures. So even though you have this NTRK and it drives the cancer, none of these drugs are cures. They shrink it, but you have to continue on the drug until you can continue to stand it. And as long as you can continue to stand it, and as long as the tumors are responding, right? So it's different from traditional chemotherapy where you just take 6 months or 4 months. It's you start the drug and you keep taking it, because as long as you're taking it, it's keeping the the cancer shrunk. And then this was just to show, this is again, not thyroid cancer alone. There's very few thyroid cancers on here. They're the very light greens. But no matter what cancer you had, if you had that NTRK, you got shrinkage for the vast majority, right? There's a few there that didn't. And then the duration of response, meaning the amount of time that the tumor remained stable or continued to shrink, was fairly long. 84% of patients shrunk, and then 3/4 of them remained on study for a long time. So with that, the FDA approved 2 drugs, larotrectinib and entrectinib. They're both drugs that inhibit the NTRK. But to use these drugs, you have to know if the patient has that NTRK alteration, which means you have to either take a biopsy of their tumor or take the old tumor that is already taken out and test for it. And you have to have a test good enough to know if there's an NTRK present or not. Okay, so basically these are FDA approved for any cancer. So the insurance companies can't say no, because it's FDA approved for your thyroid cancer as well. Okay, so now you just have to have your tumor tested, right? If you have NTRK, most commonly in thyroid, it's 1 in 3, NTRKs type 1 and 3. Well, what about this other alteration or mutation called Ret, right? So Ret mutations are very common in medullary thyroid cancer, almost half. And Ret fusions, or these gene changes, are rare but present in differentiated thyroid cancer and anaplastic thyroid cancer, okay? So again, you have to have the ability to test for it. So why do we test for Ret? What can it do? So now there's a couple of drugs that have been tested where medullary thyroid cancer patients, as well as differentiated anaplastic thyroid cancer patients, got on these trials to see if these drugs work. So one of these drugs I'm sure you've heard about here was Blue 667, which is what's called a Ret inhibitor, or inhibits that Ret gene. And this is a slide to show you that patients with, they took the big study because there are Ret alterations also in lung cancer, right? And other cancers. So I'm just showing you the subgroup of thyroid cancer. Again, the waterfall plot, each bar represents a patient. And in here, there's a combination of medullary thyroid cancers, which are the light blue, and papillary thyroid cancers, which are the darker blue. And what they're showing here, remember, if these bars are going down, the cancer is shrinking. The magical line is this red dotted line here for what's called a partial response, or PR. And almost everybody gets shrinkage on these Ret inhibitors. Now, there's a bunch here that didn't reach the magical number, but they still had some shrinkage. And then there were a few here that would still be called stable disease, but they weren't going down. But the vast majority of these patients, it was helpful. And again, the duration of response, meaning the response, if it shrunk or stabilized, remained for quite some time in these patients. And the other one is called LOXO 292. So both of these now are approved. This one is approved for medullary thyroid cancer, and the blue is being worked on. And same idea here with this Ret inhibitor. I'm only showing you this, not for the details, but to show you that here on the left-hand side, you have Ret fusion positive thyroid. Those are the papillaries and anaplastics, and Ret mutant are the medullary thyroid cancer. But you can see that you had shrinkage in 78% of the Ret fusion patients and 59% of the medullary thyroid cancer patients, right? So, but you cannot use this drug if you don't know if a patient has a Ret, because if you don't have a Ret, it's not going to work, right? So there are some other potential targets like ALK, ROS. There's drugs in development again. So if your tumor is tested and you have one of these things, PI3 kinase, TORC1 or 2, then maybe there's some other drugs that can be looked at. I just showed you the ones that are approved or that we are frequently using, even if not approved. So the other reason to use biomarkers is patients who have differentiated thyroid cancer where their tumors have become resistant to radioactive iodine. Can we resensitize their tumors to take up iodine and then use radioactive iodine to treat them? And so this idea first came from a drug that is not used now, but it's called selumetinib, or a Mech inhibitor. And the folks at Memorial Sloan Kettering actually had looked at this and gave patients a month of this drug. And they found that these patients who had resistant tumors that were resistant to radioactive iodine, that they can now make the tumors take up iodine by giving them this drug. Now, the only reason I'm showing you this in a biomarker talk is I want you to notice that 9 out of 14 patients had either a BRAF or an NRAS mutation that took up iodine. Okay, so maybe there's something there in those differentiated thyroid cancer patients that have those mutations. Maybe we should look at resensitizing those. Another study out of Mass General looked at using a BRAF inhibitor called dabrafenib in patients who have a BRAF mutation, because BRAF inhibitors don't work if you don't have a BRAF mutation, right? And they found the same thing, that patients who have a BRAF mutation, you give them a BRAF inhibitor, we can sensitize their tumors to radioactive iodine. So we looked at our experience at MD Anderson, and the reason I want to show you this is to show you what iodine uptake looks like. So to describe what happens, you give a patient a targeted therapy for, let's say, 1 to 2 months. Now, in some patients, when we looked at our what's called retrospectively, we had some patients on long-term therapy, and then we said, hey, this data has come out. Let's just do a whole body scan while they're on this treatment anyway to see if they take up iodine. Okay. And so this is a patient who, we call this a negative whole body scan, because the black that you're seeing is stomach, bladder, and this is normal, what we should see normally. The lungs are here, situated right there. And after giving them a targeted therapy, look at this iodine uptake. We knew they had thyroid cancer in their lungs. Okay, so these drugs did resensitize them to tumor. This next one here, this is another patient who, this is called a negative whole body scan, because this is physiologic, meaning normal bodily function, these uptake spots here. But look at what happened here in the lung, right? The thyroid cancer in the lung is lighting up. Okay, so these drugs can do this. And so if we say that, hey, looking back, as we look more carefully at this data, maybe it's those patients who have certain mutations and you give them certain drugs. There was just a paper published in the New England Journal showing a case report of a patient who had an NTRK alteration, got some larotrectinib, and they had uptake of iodine, right? So this isn't limited. I'm not saying this is limited to RAS and BRAF. I'm saying there's so much more to learn, and we need to think about this. Now, when we, a disclaimer, when we treat these patients with radioactive iodine, it's not curing them. It's not like the original, when you first gave them iodine and then that potentially could be it, or 1 or 2 treatments. It is that you give them the drug, you do the iodine scan. If they uptake, you treat them with iodine, you take them off their targeted therapy. So they get a break from their targeted therapy. You see them back in another 3 months or so, and another 3 months, and they get a drug holiday until it grows again, which is typically about a year and a half is what the data is sort of showing. But hey, a year and a half off of your systemic therapy is great, right? So I want to show you another way of using biomarkers. So this is a patient who had medullary thyroid cancer. and had gone through several lines of treatment, many different drugs, and then just kept progressing. So at this point, right, we had tested his tumor up here for back here to see what mutations it had. But when he kept progressing through all these drugs, well, he was doing really well, but then eventually he just progressed, and we're like, okay, we don't have many options. Let's do a blood test, okay, or a liquid biopsy, what we talked about earlier, and measure and see if we get a new mutation. His tumor originally had a Ret 918, which is the most common Ret mutation in medullary thyroid cancer. But then his blood had shown later, after exposure to all these drugs, that he had developed a what's called a Ret 804. So his original was a Ret 918, and now he developed a Ret 804. And the reason that's important, the reason I'm mentioning this, is another use of biomarkers is when a patient is progressing, have they developed a new mutation? So this patient developed a new mutation that was making him resistant, and we know all the drugs that we gave him before don't work against that 804. So then, you know, he goes on one of the newer, he went on the clinical trial with the Ret inhibitor, which does inhibit that 804. So it can change the management of patients with advanced disease. And these mutations that are resistant to kinase inhibitors are called gatekeeper mutations. So this is, you know, I'm not telling you this for the details. I'm just, again, showing how these can be important. So, and to summarize, who should get biomarker testing? Well, not everybody, okay? And why do I say not everybody? Because I want to point out, remember, and I'm going to come back to this slide. Don't worry, guys. Okay. And so if we take all the differentiated thyroid cancer, remember that the radioactive iodine refractory differentiated thyroid cancer is 5% of the whole circle. So yes, if you are one of those patients, radioactive iodine refractory with differentiated thyroid cancer, this is very important and we need to do it, or even in the metastatic group there, right? But if we take all differentiated thyroid cancers, and 40 to 70% of those patients will have a BRAF, 40 to 70% of those patients have a BRAF. But you can look at this data set and say the vast majority of patients with differentiated thyroid cancer are going to do great with surgery, with or without radioactive iodine. Then just because I take your tumor early on, test it, and get a BRAF does not mean you're going to do poorly. I cannot repeat that enough. Doing biomarker testing in every patient with differentiated thyroid cancer can lead to increased anxiety and people treating wrongly. Most patients are not going to need that BRAF inhibitor. Okay, so that brings me back to this slide. Who are the patients that actually need the testing? And that's the reason this lecture was called Advanced Cancer. Right? So it's patients in whom you think in the future that testing, or even now, that testing is going to make a difference. So the vast majority of those patients are patients who you think may need systemic therapy. Okay. So for differentiated and medullary thyroid cancer, I'm going to put those two together. I know we usually don't put those two together. It's advanced patients, meaning those patients who surgery cannot remove all the disease. It could be all localized in your neck, but it's stuck onto different organs, and that the surgeon going in is not going to be able to remove the disease. Now, this is not in the guidelines, but one of the things that we think about and we're doing trials on is what's called neoadjuvant. So first giving, if we test the tumor, we find a biomarker, can we give a targeted drug against that biomarker, shrink it, so now the surgery will be easier. Right? So that's one category of patients. The other one is patients who have metastatic disease. Now, you don't know if that patient is going to get into trouble with their metastatic disease or not, but you can do your biomarker testing in advance. So you know if this patient progresses, this is somebody I would test. And for sure, if you're going to start it. But in general, even if you're not going to start therapy now, that patient, you may need it. And then all patients with anaplastic thyroid cancer should get biomarker testing, because the vast majority of these patients need systemic therapy, and this is a systemic disease, and we can change those patients' lives. So I use this to remind everybody that, you know, there is so much we have to learn. So if you look at this graph and you say the x-axis is the normal lifespan, okay, so you want to reach the goal line, here the red, and the y-axis is the volume of disease. How much thyroid cancer do you have? Okay, then patients who have thyroid cancer that responds to radioactive iodine in general reach their goal line. Okay, patients who have anaplastic thyroid cancer in general don't reach their normal lifespan or goal line, right? But the reason I'm showing you this is patients who have differentiated thyroid cancer who are refractory to radioactive iodine. Some of these patients will reach their goal line. Some patients won't, okay? Their tumor just grows fast. And we don't have a very good idea in the beginning how to predict that. So this group of patients, well, oops, sorry. The anaplastic thyroid cancer patients should get biomarker testing. The radioactive iodine refractory patients, if you're thinking that at some point, then you can't surgically remove it, and at some point you may think about systemic therapy, having that biomarker testing in case you're one of these patients is important. Now, if you have it in one of these patients, it doesn't mean that you'll have to act on it. Okay, so that is what I wanted to show for that. And remember that this is an alphabet soup and it's forever changing, and we're updating things as fast as we can. Drugs are being updated, biomarker testing is getting updated, and things will get better over time. If anyone's interested in where are there clinical trials for thyroid cancer with my specific type of thyroid cancer, clinicaltrials.gov is helpful. Google's always great, right? But clinicaltrials.gov is helpful. The ATA, MD Anderson, lots of institutions will have a website as well. The clinical trials should get the entire nation. And this was many years ago at one of the American Society of Clinical Oncology, where the presidential address I thought was really good. And they were talking about, we have changed, we're in a different era now, right? Unfortunately, cancers are not stupid, right? They're not just have one abnormality and that one drug is going to work. It's rare to find that, right? And then no resistance, right? That's why we don't have cures very often, right? But the cancers are smart. They have lots of mutations. They have lots of these abnormalities. And so you use one drug, boom, it'll increase the cells that have a different one and or develop resistance later. They get, you squish out the ones that you know about and the other ones come out. And so we have to think about multiple drugs and smarter drugs and start thinking like a cancer. So our goals in personalized medicine is we have to find the right patient, meaning what are the abnormal pathways or genes in this specific patient, and that's where biomarker testing comes in, and then find the drug that can work against those targets, and then what's the dose in this patient, and specifically for thyroid cancer, what's the right time to start treatment, right? If we had a cure, we'd say, do this treatment as soon as you know they have disease. But because it's not a cure, it's very careful. You have to find that inflection point when they need it, because you don't want the treatment to be worse than the disease. The goal of treatment is to prolong life without affecting patients' quality of life. So how are we going to do that better? Well, we have to keep trying to identify novel drugs. We have to advocate for biopsying the tumor and send it for molecular testing. And there's many different ways to do this and many companies and many ways to measure it. And then testing the blood for the molecular testing may work well for anaplastic, but it doesn't work very well for differentiated. And it does work well for some medullaries, but not all. So just to remind everybody that there are novel targeted drugs that we have access to, right? The immunotherapies, if you have that microsatellite instability, which is very rare, unfortunately, in thyroid cancer, the NTRK inhibitors, the Ret inhibitors. And then we have some drugs that are not approved, but we can use them off label depending on what mutations we have. Now, Ret inhibitors have moved up and they're FDA approved, but BRAF inhibitors are only approved for anaplastic. And so that is still considered off-label. So with that, I want to acknowledge that I happen to be up here talking, but it takes a multidisciplinary team. We all work together. And of course, at the center of our team are all our patients. So thanks to all of you who trust us with your care so that we can learn and do better and find the cure. And together we can do this. So thank you. So with that, I'm going to end my show and go to the my talk and go to the Q&A and try to read out the questions. I think we have 10 minutes. Is that correct?
Yes, we have about 10 minutes and we can go over a few minutes if you're available and if needed, but not more than just a few. Okay,
fantastic. Okay, so I'll start at the top. So papillary thyroid cancer, lymph nodes picked up radioactive iodine. I'm going to read it quickly, but I'll summarize the question. Lymph nodes were not completely ablated despite intense uptakes. Subsequent REI tracer uptake were clean. Lymph nodes were still malignant, confirmed. Does that mean there was some tumor mutation within 6 months? Okay, so the question is a patient who has papillary thyroid cancer, and after their thyroid was removed, the radioactive iodine scan took up took up iodine, but then after that they had what's called diagnostic whole body scans, or to look if there is some uptake of iodine. At 6 and 12 months later, they had an ultrasound with a biopsy that showed they still had disease, but the iodine pictures were not showing it. So they're asking, does that mean that in that 6 to 12 months my tumor changed or mutated, and that they're radioactive iodine resistant? So what I'm going to say is that if you have an iodine scan, right, and you have known tumor on an ultrasound biopsy proven that is thyroid cancer, then by definition, you have thyroid cancer that's resistant to radioactive iodine. Okay, that's assuming you didn't just have a CT scan with contrast and that the iodine scan is false. So yes, so by definition, this patient has thyroid cancer is resistant to radioactive iodine. Now, the question about did it mutate or not? So typically in thyroid cancer is very hodgepodge, what do I call, mixed, okay? Meaning you can have some lymph nodes that take up iodine and some that don't. It's not it's one cancer, but it's very mixed. And so the ones that took up iodine probably got the iodine in, may have had them treated. But then the ones that were there that didn't take up iodine, you can leave a little nidus, and then 6 months, 12 months, a year, 2 years later, those can grow. And now they look bigger because that iodine never really touched them. Or part of the same lymph node, part of it takes up iodine, part of it doesn't. Okay. Oh, and then part of that question was, does it mean that those that the diagnostic tracer dose wasn't enough? So there's a lot of argument in the data that taking the tracer dose may not be enough. It really only changes management about 2% of the time. Most of the places in the country don't do diagnostic scans, but no, they were probably resistant from the beginning, to answer your question. Okay, can old tumor remnants, oh, sorry, this flips up. Anyway, can old tumor remnants be tested if the current tumors in the persistent disease are an area that is difficult to access or biopsy? I have papillary, but did have some tall cells that were found previously. Okay, so the question is, if thyroid cancer that's been removed by surgery, whether it's recurrent or primary, can you test that? If you have cancer in you now, can I test the old tumor that's already out? And yes, more often than not, the tumor that's already there is, the tumor that's already out can be tested for those genes. The idea of fresh tumor testing versus old tumor testing, it's always better to get fresh disease because you don't know if something's mutated, okay? But the vast majority of patients have a BRAF or a RAS, which are there from the beginning, and you don't lose those. If anything, your new tumor may gain things. And the things typically that differentiate thyroid cancer tumors are gaining are like PI3 kinase, P53, and those currently with approved, available drugs don't have something. I know we don't know as much about Ret and NTRK, but we think that you don't tend to gain those except the resistant kind. Oh, and sorry, tall cell tends to be more resistant to radioactive iodine. Do I have classical variant or follicular variant? Okay, so in general, there are different types of histopathology of thyroid cancer, classical variant, follicular variant. All those are considered, and tall cells, all those are considered papillary thyroid cancer. And in general, we think that follicular variants act just like papillary thyroid cancers. So don't focus too much on that histopathology. That histopathology does not necessarily determine that biomarker testing. And it doesn't necessarily predict what's going to happen to you. So your best bets are still the thyroglobulin and the ultrasounds, and if you end up needing biomarker testing. Okay. Okay, what type of radiographic imaging is recommended for asymptomatic, stable, refractory, metastatic differentiated thyroid cancer? So if a patient has differentiated thyroid cancer, papillary follicular, and it's spread outside of the neck, right? And it doesn't take up iodine, so it's radioactive iodine refractory, what do we typically recommend? So actually, the guidelines say that those patients should get Imaging of their neck, because thyroid cancer loves the neck. So if you have good ultrasound, do an ultrasound, a CT neck if you don't have good ultrasound, or if you're worried about deeper disease like trachea and things that you can't see very well with ultrasound. And then the next place thyroid cancer likes to go is the lungs. So do imaging of the neck and imaging of the lungs and look at thyroglobulin, and do that initially you probably do it every 3 months a couple times, and if things are stable, every 6 months. And if you don't see it in the neck or chest, then, and your thyroglobulin is greater than 10, you can do a PET scan. If you have 2 tumors, can one have BRAF and one have a RAS? Okay, so very good question. If you have, often you'll have multiple thyroid cancer, multiple spots of thyroid cancer. There are some abnormalities that we think that you tend to maintain. So BRAF tends to be in the vast majority of your cancer, but you can have heterogeneity in your thyroid cancer. So usually BRAF is in all of it. Sometimes you'll have a little section that doesn't have that BRAF. But you typically don't have BRAF and RAS tend to be mutually exclusive. Now, the exception to that is people who have been on those drugs, and sometimes they can then develop a RAS after a BRAF. That's a different story. So if that's what you're referring to, then that can happen, but that's exposure to drugs. Usually BRAF and RAS are mutually exclusive. We think that RET and NTRK are mutually exclusive as well, but we haven't done enough testing to say that for sure. Is there a maximum amount of radioactive iodine that you'd give where it's still working? Thyroglobulin drops to 20 and holds for a year and then rises quickly again. Patients already had 900 millicuries. So typically, in general, people say, we don't want to give more than, if your tumor you've received more than 600 millicuries of radioactive iodine, you're probably resistant. There's no sense in keep giving it. But remember, all this data has changed over the last 5 to 10 years. So we didn't have anything other than iodine before. So a lot of patients have gotten a lot of iodine already, but if you've gotten more than 600, you are typically resistant to radioactive iodine. It's not that there's a max, you can still get more, because remember, if you're getting those drugs and resensitize, you can use fancy things like dosimetry to see if you can get more, but in general, your body's telling you that you're resistant. How often do you need a tissue biopsy? Would it show changes? I'm so sorry, these move up quickly, I apologize. How often do you need to do the tissue biopsy? Would it show changes after a few years? How do we go about doing this? Okay, so that's a great question. So if you get biomarker testing and you don't have tumor that's easily accessible to test, then your total thyroidectomy or your thyroidectomy tissue that was there that's tumor, you can have that testing ordered. Now, they are commercially available if your doctor's office doesn't have their own testing. Some institutions have their own testing, and you just have to ask your doctor. It's not like you can just go up and order it yourself. And so you have to talk to your doctor about, hey, would tissue testing be helpful in my case? And again, I would only do biomarker testing if it's going to change the management. So you want to ask your doctor, what would you do differently if we do tissue testing? And does it need to change after a few years? So again, if you get tissue testing on the latest piece of tissue, it's the most informative. But if you get it on the original, that's something's better than nothing. Like there's some patients where it's too hard to biopsy or the risk is too high. Is there a case to be made for testing all patients for biomarkers at the time of diagnosis or surgery? No. No, there are people who advocate for that. I want you to be wary, because what are you going to do? Every testing has a risk. Every testing has, and that risk may even be just increasing anxiety with nothing to do about it, right? It's not that, hey, well, I want to know. Well, what do you want to know about it for, right? So if I have imagine I have a 1 centimeter papillary thyroid cancer, I biopsy it and I send it off and I have a BRAF. Does it change the fact that I can go under observation or undergo a lobectomy, half the thyroid removed, right? Does it? No. Doesn't matter if you have a BRAF or a non-BRAF, because remember, 40 to 70% of papillary thyroid cancers will have a BRAF. But what percent of patients get into trouble or have a recurrence, right? Or have it metastatic? It's 5 to 10%. So yes, you don't know if you're going to be one of those people. The only way you're going to know the best chance at getting rid of it is that surgery. That BRAF did not change the surgery. So no. Do mutations and fusions change over time? A BRAF positive anaplastic thyroid cancer patient who's currently on a BRAF inhibitor and a Mech inhibitor and Keytruda, when resistance occurs to kinase inhibitors, is it advisable to retest genomic profile? Absolutely. So let me explain what that Let me explain what that question means. So patients who have, you've tested your tumor, the mutation is a BRAF, you've been on the drugs that inhibit that BRAF, this patient is on 3 drugs, and then something grows. Definitely that is a patient who, in anaplastic thyroid cancer, you could actually do a liquid biopsy and biopsy the tumor if you can get it and test for it. Because number one, there isn't a lot known about those patients, but if you find a new one, in our cases, those patients are developing RAS mutations, then you can say, hey, I may still need 2 or 3 of those drugs that I'm on, but I may need an additional drug, or there may not be a drug that can attack that. Maybe I radiate that one spot and continue on the drugs. So yes, so that is definitely advisable. Resistance on therapy is advisable. Is liquid biopsy more effective in poorly differentiated thyroid cancer? So liquid biopsies, when you draw the blood, and again, poorly differentiated thyroid cancer has a big range. Remember that chart I showed with the radioactive iodine resistant differentiated thyroid cancer? Poorly differentiated falls on that spectrum. So clinical scenarios drive that one. If you have the more aggressive kind of poorly differentiated, then liquid biopsy probably will pick it up, whereas it may not. And remember, tissue testing is still the gold standard. But some poorly differentiated, you remove them and they don't, have a problem, or they're stable, and liquid, it's not shedding enough tumor to pick up on a liquid biopsy. Could you talk a bit more about TERT mutations? Would that increase more mutations over time? Okay, so what they're talking about is many times on thyroid cancers, you can have something called a TERT promoter mutation. And those, and specifically, you can see it with RAS or with BRAF. And yes, it can make the thyroid cancer more aggressive, but there isn't a drug to target it. Okay, so it's not that, yes, you test for it and you know that, okay, it's prognostic, that patients may have more aggression, but it doesn't necessarily say that it's going to increase your risk of having a RET or a RAS. It's just that the RET or the RAS are what's called targetable, and right now the TERT is not targetable, but they can coexist. How do you decide whether to use just a BRAF inhibitor or both a BRAF and a Mech inhibitor? And that is a very good question. If you have anaplastic thyroid cancer, you should go on both. If you have differentiated thyroid cancer, we don't know the answer. We just completed a randomized controlled trial, which means half the patient got a BRAF inhibitor and half the patients got a BRAF and a Mech inhibitor. And statistically, we could not see a difference, but the feeling we all get is the patients who have more aggressive disease, we tend to give both, and less aggressive disease, you start with the one. And what we do know from that trial is if you start with just the BRAF inhibitor and then you progress, you can add the Mech inhibitor with the BRAF inhibitor and it'll work. Do we still have time? Are we okay? Okay, so before I ask anything, thank you, Miss Holiday. She's saying she wants to thank us for all that we do. And she runs the radioactive iodine resistant Facebook group for patients with radioactive iodine refractory disease. And so thank you, number one, for running that Facebook group. A lot of patients love having, support. And so thank you for all that you do. My biggest question is why we are not testing for why are we not testing for radiosensitive oncogenes like ATM and TP53 before patients are given radioactive iodine or beam radiation? Awesome question. And what do you do if you have these other germline mutations that are throwing monkey wrenches in your treatment? For example, mast cell disorders causing bad reactions to medications and strokes and medications. Okay, so let me summarize what that question is asking, because it's probably it's a very good question, very advanced question. So there are certain genes that currently are not targeted. So the gene panel sometimes can test for 200 and 400 genes, and genes that we don't currently have drugs for, and we don't know what to do with, but they can suggest that a cancer is more aggressive. So P53, ATM are found on more aggressive thyroid cancers, but current drugs don't target them, right? Now, they can be more sensitive to radiation, and potentially one can envision to radioactive iodine. But unfortunately, the tumors that have those are resistant to radioactive iodine. Now, her question is saying, hey, well, you just told us you can give a targeted therapy and sensitize some tumors to radioactive iodine. Yes, but we don't know. So I can take 2 patients with a BRAF mutation. One with a BRAF inhibitor will not get sensitive to radioactive iodine, and the other will. And we don't know the difference. And some of that is that the more mutations somebody has, the more aggressive their disease and the less likely they are to take up radioactive iodine, but we don't know that. There's so much research that needs to be done. And if somebody has a germline P53, which means a hereditary P53, that's something called Li-Fraumeni syndrome, we actually shy away from radioactive iodine, because if you have a P53 in every cell of your body, we worry theoretically that we could induce another cancer. So sometimes germline mutations can throw monkey wrenches, as you're saying, but make other diseases worse. So we take all that into account. So on an individual basis, we have to talk to the patient about the risks and benefit of the radiosensitivity, what it may do to the other organs of their body. So it's not just about their thyroid cancer, because you're a patient as a whole. So hopefully that answers it. But we don't know that ATM and P53 tumors will do better with radiosensitization. In fact, we may have some evidence to the contrary, but not sure, although it's counterintuitive.
So I think we have time for one more question, and then I'm going to go ahead and I'm going to copy the remaining questions so that we can get back with the participants.
That sounds fantastic. Okay. And then where do I put the answers so the participants know?
I'm going to work with Gary on that. So I'm copying them into, but thank you. We'll be in touch.
Okay. So I'll just reply the answers to your email, and then you can get back to the participants. Fantastic. Some of these participants don't have last names, but we'll look for them. Okay. Do any type of cancers respond better to NTRK inhibitors? I'm going to see if I can answer more than one of these questions in one go. And then any long-term effects of being an NTRK inhibitor. Okay. Okay. So there's several questions about NTRK. So I'm going to try and talk really quickly about that. Fantastic. Okay, so about the several questions are about the NTRK. So I want to address in general what the questions are asking is, if somebody has an NTRK mutation, are they likely to be able to resensitize with radioactive iodine when they're given an NTRK inhibitor? And the answer to that is, we just had a case report published in New England Journal showing that a patient who was on an NTRK inhibitor, who was radioactive iodine refractory, then did another iodine scan, and they did take up and they were treated. And we also have one now at MD Anderson. I mean, there's probably others in the world, but they haven't just been published about, so we don't know as much. So there may be something to that story. It needs to be worked up and studied better. If a patient already has a BRAF and a TERT mutation, but did not test for NTRK, we don't think that they're going to have an NTRK, but again, fusions were very often not tested. Because some of these are in similar pathways, so we don't think they could have both. But we are going to, if you've been on systemic therapy, we're going to learn more about that. So some of these questions we can't answer yet. If you have BRAF, and where was the other NTRK question? Somebody asked something else. Yeah, so when you're on these NTRK when you're on any of these targeted therapies, to answer two of these questions in one go, when you're on any of these targeted therapies and you see your thyroglobulin rising, right? All of us assume that in a differentiated thyroid cancer, all of us assume that means that the thyroid cancer is growing and maybe there's a problem. But sometimes on these targeted therapies, it's increasing a little bit, and that is predicting those who will be able to resensitize to radioactive iodine. So that'll be a very individual thing. But yes, they should be looking for progressive disease. But if they don't see it, I wonder if it's one should be tested for sensitization to radioactive iodine.
Thank you so much, Dr. Busaidy. This was really, really informative. We so appreciate your time and your extra time to answer all of these questions.
No, thank you very much. And thank you all of you for your attention. It was a beautiful group and fantastic questions. They're all good as usual. ThyCa, the group that comes to ThyCa and asks these fantastic questions. Thank you to you all. You make us think, you ask all these questions. It makes us go back and do more research, and we will find this cure together. So thank you so much, everyone.